Hello again, this is Dr. Omid, and in this video I'm going to talk about the joints of the upper limb. As you see, here I am at the dissection room. So because the preparation, they are not the dry preparation, they are inside the boxes that they contain the formalin and alcohol. So concerning the joints of the upper limb, what you have to know generally about joints. First of all, you have to know the name of the joint. This is the first thing. Second thing that you have to say is this joint is between which bones. Then the third things, you have to explain the articular facet. It means that the articular facet of this bone is articulated with the articular facet of that bone. Fourth, which is very important, is the type of the joint. The type of the joint we can explain in two ways. Either the joint is simple, or compound, or composite, or complex joint. Simple joint is the joint that is between two bones without any the articular disc or menisc. This is called simple joint when they are between two bones without any disc or menisc. The composite or compound or complex joints, they are the joints that they are more than two bones it's playing, or they are forming this joint. This is one. Or at the joint cavity or at the between the articular facet, there are articular disc or menisc. So whenever you see disc or menisc or the joint that is composed of more than two bones, this is composite or complex or compound joint. Next important structure that you have to discuss about each joint is articular capsule. Articular capsule, you have to explain that is starting from where, is originated from where, and is inserted where. If the capsule is rigid or tough, or if it is lax and is allowing the movement at the joint. Generally, the capsule of the joint, it has two layers. One outer layer which is formed by the connective tissue, and the inner layer which is producing synovial fluid, which is important for the lubrication of this articular facet. And next thing that you have to discuss is are ligaments, or the structure and ligaments that there are for the extending of this capsule or this joint. They are existing, and you have to know again this ligaments is originated from where and is inserting where. And finally, about each joint, you have to explain the movement, that the movement at that joint, what are they, and you have to know in which direction they are. Another classification of the joints is according to the shape of the articular facet. So one classification was according to the type, for the type of the joint, is if it is simple or compound, that we explained it, and another classification of the type of the joint according to the shape of the articular facet. For example, if articular facet, at the articular facet we have one ball-shaped structure and one fossa. This is called, according to the shape of the articular facet, ball and socket joint. Or for example, the elbow joint, if you have trochlear shape of the humerus and the trochlear notch, so this is hinge joint shape, and so on, that we will discuss it for the individual joint separately. So first joint that we are going to discuss is the sternoclavicular joint. Sternoclavicular joint, according to its name, is the joint between the sternum, respectively is the manubrium of the sternum, and the clavicle, respectively the sternal end of the clavicle. Then we said that for each joint you have to say between which bone. We said the sternum and clavicle. Then you have to say about the articular surface. The articular surface of the sternum is the clavicular notch, and the articular surface or articular facet is the sternal articular facet at the sternal end of the clavicle. Then we said that we have to say about the type of the joint. The type of the joint here and also here is better to see because of the location of the disc, articular disc. So we have the compound or composite joint, and according to the shape of the articular facet, because the sternal end of the clavicle looks like a ball shape approximately, and here the clavicle, the clavicular notch at the sternum, it's a fossa. So the type of the joint according to the articular facet is ball and socket, and according to the simple or compound is compound because of the existence of the articular disc. As you see, this articular disc, which is the fibrocartilage structure, is dividing the joint cavity to two parts. One part was here, and the other part was here. You can see it by the extension of this bone. Then we said that we have to talk about the articular capsule. Articular capsule, as you see, which is around the joint, is located. It's very short and is very rigid and firm, so it's limiting the movement at this joint. The ligaments that they are strengthening this joint, they are the sternoclavicular ligaments, that there are two groups, anterior and the posterior here. So anterior and posterior sternoclavicular ligament. Then another ligament that you can see here is interclavicular ligament, which is the bridging above the jugular notch that we said it at the bone session for the sternum. And the last ligament, as we mentioned before, here near to the sternal end of the clavicle, we had the impression for the costoclavicular ligament, and this is the place that the costoclavicular ligament that is from the first rib. Here is the cartilaginous part of the first rib. You can see it here and here. So, and here also there is a ligament which is the costoclavicular ligament is attaching here and is strengthening this joint. Last thing is movement about the movement of this joint. The movement of this joint, it's because it's ball and socket. It has a 3 degrees of freedom of the movement, and because of the tough and rigid and short articular capsule, the movement is in all direction, but very limited range of the movement. Next joint is the acromioclavicular joint. Acromioclavicular joint is the joint between the clavicle and the scapula. The part or the articular facet is the articular facet at the acromial end of the clavicle and the acromial articular facet of the scapula. This joint we have the articular capsule very tough and rigid. So that's why is allowing very minimum movement. The joints that they are tough and rigid, and the articular capsule they are very tough, they are called amphiarthrosis. So this joint is somehow flat joint, rigid joint, and amphiarthrosis. And according to the articular, the shape of the articular surface, and according if it is simple and compound is a little bit difficult in this joint, because sometimes at the joint region between the articular facet, it might exist an articular disc, and if it is articular disc present, so is a compound, and if is not present is a simple joint because it's between two bones. So back to this joint, as you see the articular capsule is very tough here, and one ligament which is going above this joint, and it has the same name of the joint, is called the acromioclavicular ligament. It's stringing this capsule, and in this case is firming this joint. Then here I have another joint, and it's very important joint, which is shoulder joint, or the glenohumeral joint. The shoulder joint or glenohumeral joint is the joint between the humerus and scapula. The joint between the articular facet is head of the humerus and the glenoid cavity of the scapula. So the type of the joint, because it's between two bones, no articular disc or menisc, so in this case is simple joint. According to the shape of the articular facet, because it's a ball shape, and here is the fossa or cavity, it's called ball and socket. Ball and socket joint, as you saw in the lecture, they have the 3 degrees of the freedom, and the movement they are in all directions that in a while we are going to discuss. Very important is that the discrepancy between the size of the head of the humerus and the glenoid cavity. As you see, the head of the humerus around 3 to 4 times bigger than glenoid cavity. So that's why this joint, ball and socket, is called usually free ball and socket or arthrosis. Vice versa of the hip joint that we are going to discuss is the limited ball and socket and is anarthrosis. This joint, which is a shoulder joint, is free ball and socket and arthrosis. It means because of this discrepancy is the most movable joint of your body, that is allowing you that you reach to the subject that you want. As you see at the margin of the glenoid cavity, here is very nice seen, is a fibrocartilage structure that is increasing the margin of the glenoid cavity a little bit. This structure, as you see, this is called glenoid lip or labrum glenoidale, which is a little bit increasing the size of the glenoid cavity. Concerning the capsule, the articular capsule, as you see, is lax, is allowing you to move this joint in several directions. The capsule is starting from the beginning of the glenoid cavity at the margin of the glenoid cavity, and it reached to the till anatomical neck of the humerus. So we said that is movable, and the capsule is become strong thanks to the ligament. This is the coracoid process. So there is a ligament that is coming from the coracoid process to the anterior side of the capsule to the humerus. Is called coracohumeral ligament. Then another ligament that is not seen well, but it's starting at the margin of the glenoid cavity to the anterior side of the humerus, and usually we classify them to the superior, middle, and inferior. Is called glenohumeral ligament. Then another ligament here, it's seen much more better in this preparation, is originated from the coracoid process to the acromion and above the shoulder joint, is called coracoacromial ligament, and it's because of the position above the shoulder joint is called fornix humeri, or humeral fornix, or fornix humeri, or another name is coracoacromial ligament. Is limiting the movement of the abduction above the horizontal plane. Here there are two important ligaments that I mentioned it in the bone of the clavicle. This is the coracoid process that you can see, and from the coracoid process, this two ligament is attaching to the clavicle. All this ligament together is called coracoclavicular ligament. Coracoclavicular ligament. Coracoclavicular ligament, it has two parts. One part which is attaching or is inserting to the conoid tubercle, as you see, is in dorsally, inferiorly, and more medially. This ligament that I catch it with the pincet is called conoid ligament, and it's the first part of the coracoclavicular ligament. And another ligament here which is attaching more anteriorly and more laterally, and also is in the inferior surface, and I catch it, and is attaching to the trapezoid line of the clavicle, is called trapezoid ligament. So conoid ligament and trapezoid ligament, they are the two components of the coracoclavicular ligament. In another preparation also I can show you, maybe it's better. Here is the coracoid process. Here is the coracoid tuberosity of the clavicle, which are composed of conoid tubercle and trapezoid line. So this part is the conoid ligament, and this part is the trapezoid line, which is more laterally is located. And there are two components of the coracoclavicular ligament as a whole. Here I have another ligament that I already mentioned at the superior margin of the scapula. Here we had the scapular notch. And here you can see this ligament is bridging above the scapular notch and is called superior transverse scapular ligament. This superior transverse scapular ligament is bridging above this notch, and is now we don't have a notch, we have a foramen, and later in the preparation you can see that here it passed the supraclavicular nerve, and above this ligament it passed the supraclavicular vessels. Back to the shoulder joint. In addition of all these ligaments that we mentioned, there are a group of muscles that they are playing role for the firming of this shoulder joint to hold this head of the humerus inside the glenoid cavity. And those muscles, they are rotators. So they are, as a function, they are making external rotators and rotation and internal rotation. So that's why all this group of this muscle, they are called rotator cuff. The muscles of the rotator cuff. The border, these muscles, we are dividing to two groups, the anterior group and posterior group. And all these muscles, they are going behind the articular capsule. The border between these muscles is this tendon. This is the tendon that, as you see, is arising from the supraglenoid tubercle here, and it goes inside the capsule, and here it's coming out of the capsule, the same tendon, and it goes to the intertubercular groove. This is the tendon of the long head of the biceps brachii. And this tendon, it's dividing the muscles of the rotator cuff to posterior and anterior. The anterior group are two muscles that they are subscapular muscle, which is located in the subscapular fossa. You can see the line, the muscular line for attachment, and teres major. And these two muscles, they have a function as an internal rotation. The posterior group that is divided by the tendon of the long head of the biceps brachii, they are infraspinatus muscle, which is located in the infraspinal fossa, supraspinatus muscle, which is located in the supraspinatus fossa or supraspinal fossa, and teres minor. These three muscles, they are the posterior group of the rotator cuff, and they are doing the external rotation. So those muscles also, they have very important role for the firming and strengthening of the shoulder joint and keeping the head inside the glenoid cavity. Again, you can see whenever you see a tendon that it passes through the intertubercular groove, so is the tendon of the long head of the biceps brachii. And here again is the structure. And the last thing is the movement of the joint. So the normal anatomical position of the human body is like this, that the hand, they are in the supinated position. It means that the thumb, they are outside and the small finger is inside. So the movement at the shoulder joint, we said that is because of the ball and socket, and the free ball and socket is the most movable joints of your body, and that's why this joint is the most common joint that it will be dislocated by the injury or by the disease. So the basic movement at the shoulder joint is toward forward is flexion, toward backward is extension, which is mean degree than flexion. Then far from the body is abduction, close to the body is adduction. Then we have internal rotation and external rotation, and combination of all this movement is circumduction. So once more, flexion, extension, abduction, adduction, internal rotation, external rotation, and circumduction. Also, a scapula, inside or between the muscle, it has its own movement. The movement of the scapula are following: elevation toward upward, depression is toward downward, protraction, it means that toward anteriorly and laterally, and retraction is toward dorsally and medially, and also the scapula has rotation movement. Next joint of the upper limb is elbow joint or articulatio cubiti. As you see here, this joint is between humerus ulna radius. It means that 3 bones that they are in this joint, and because of this we have the compound or composite joint. This joint is composed of 3 joints, as a matter of fact. Between the humerus and ulna is called humero-ulnar joint. Between the humerus and radius is called humeroradial or radiohumeral joint. And the proximal radio-ulnar joint. First joint is between humerus and ulna, is humero-ulnar joint. The part is, or the articular facet are the trochlea of the humerus. Here, again, medial epicondyle is bigger than the lateral. The trochlea of the humerus and the trochlear notch of the ulna. This joint is, according to the shape of the articular facet, is hinge joint, because and the most important movement at this hinge joint is flexion, extension, flexion, extension. Next joint is between the humerus and radius, humeroradial joint. The articular facet are the capitulum of the humerus, and as we mentioned, here at the top of the head of the radius you have the articular fovea. This is articular fovea. According to the shape, you see a fossa and or socket and ball-shaped head. So the type of the joint is ball and socket. This joint is helping the flexion and extension and is allowing some rotational movement. Next joint is between the proximal part of the radius, which is the head of the radius, and proximal part of the ulna. The articular facet is the circumference articular facet at the head of the radius, and the radial notch. Here it's well seen. The circumference articular facet of the head of the radius, and here is the radial notch of the ulna. The type, according to this the shape of the articular facet, is pivot joint. So the articular capsule, as you see here, it's a little bit lax, as you see. It's allowing some movement. Articular capsule, be careful, is not covering the medial and lateral epicondyle. The medial and lateral epicondyle must be out of the articular capsule for the attachment of the tendon of the muscle. So the extension of the articular capsule around the neck of the radius, it has a specific terminology which is called recessus saxiformis. The ligaments that they are strengthening the articular capsule are the collateral ligament, that they are the medial collateral ligament that is starting from the medial epicondyle and is attaching to the medial side of the ulna, is stronger, and the lateral collateral ligament, which is starting from the lateral epicondyle and is ending to the annular ligament that in a while I will tell you, to the lateral aspect of the head of the radius. This ligament, that I have it in my pincet, and it's turning around the circumference articular surface of the head of the radius and is inserted to the anterior and posterior side of the radial notch of the ulna. So this ligament is called annular ligament. Annular ligament. Those are the ligaments. There are some ligaments that they are joining the radius and ulna, and one ligament which is connecting, here is not that much seen, is connecting the neck of the radius to the ulna, is called quadrate ligament. This is one ligament. And another connection between the radius and ulna, this is the radius and this is ulna, is this tough membrane which is obliquely from the interosseous margin of the radius is going downward to the sharp edge interosseous margin of the ulna. This is called, that's why, interosseous membrane, and is connecting the radius and ulna together. There is an opposite direction that usually around the ulnar tuberosity toward the radius. It means that vice versa of the direction of the interosseous membrane, it means from the radius to ulna. Here it is from the radius to ulna, but in the proximal direction. This is called oblique cord. Oblique cord. So interosseous membrane and oblique cord. Since I have here the distal part of the radio-ulnar joint, so here you can see the distal part of the radio-ulnar joint. This is called distal radio-ulnar joint. The joint is between the distal part of the radius and distal part of the ulna. It means the head of the ulna. The articular facet is the circumference articular facet at the head of the ulna with the radial with the ulnar notch of the radius. Here is the similar joints that we have it here. If I show it to you in the proximal side, it was between the head of the radius, circumference articular facet, with the radial notch of the ulna, and it was pivot joint. Here, if I go it down, so in the distal is between the circumference articular facet of the head of the ulna with the ulnar notch at the radius, and also is pivot joint. These two joints mainly, they are making the special movement, or they are allowing a specific movement which is called pronation and supination. The supination is the anatomical normal position of the radius and ulna. It means that they are parallel with each other, and they are the interosseous margin, they are opposite to each other, and the radius is located laterally and ulna is located the medially, but and is like this. But the pronation position, which is turning the hand like this, it means that the thumb, it goes medially, and the small finger, it goes laterally. It's the pronation position. The pronation position, it means that the ulna staying at its place, the radius, thanks to these two joints, the proximal and distal radio-ulnar joint, is turning over the ulna and cross-overing the ulna. It means here it's the radius is turned over the ulna and cross over the ulna thanks to the proximal and distal radio-ulnar joint, and it's making pronation. So once more, the supination, two bones, they are opposite, parallel to each other, the interosseous margin opposite to each other, and the pronation position, ulna staying its place, but the radius is turning over the ulna and crossovering the ulna. So this is the movement at the elbow joint that I'm going to show you now in my body. So movement at the elbow joint. We have thanks to the humero-ulnar joint and humero-radial joint, we have the basic movement at the elbow joint as a flexion and extension. Extension, it doesn't go more because the olecranon that you had it at the ulna, it goes to the olecranon fossa that you have it in the humerus and is stopping the extension. As we mentioned it before, the female, they have the smaller olecranon, so that's why they have more, this allowing the more goes to the olecranon fossa and they have hyperextension. Another movement at the proximal radio-ulnar joint and the distal radio-ulnar joint, main movement is supination, which is a normal classical anatomical position, and the pronation that I explained it to you before. It means that the thumb, it goes to the medial, and the small finger, it goes to the lateral side, and the radius is crossovering the ulna. So here is the supination, pronation, flexion, extension. We continue for joints of the hand. The wrist joint is the joint between the radius and the proximal row of the carpal bone. Of course, except the pisiform, is called radiocarpal joints or wrist joint that we are going to discuss. Here you have also very nice cross section. This is the part of the distal part of the radius. This is the carpal articular surface of the radius, and here is the proximal row of the carpal bone. Next joint is the joint between the proximal row and the distal row. Here is better to see. This is the proximal row of the carpal bone, and this is the distal row of the carpal bone. And this joint is called mid-carpal joint and is S-shaped joint. Then another joints are the intercarpal joint. Each carpal bone, they are connecting together. Here you can see the interosseous ligament, that they are called intercarpal joints. The specific intercarpal joint is the pisiform joint or the pisotriquetral joint, the joint between the pisiform and the triquetrum. That is the separate joint, and it has the separate capsule. Another joint that we are going to discuss is the joint between the distal row and the base of the metacarpal bone. Is called carpo-metacarpal joints. We said it, we already mentioned it, and we are going to discuss it. Very important joint is the first, the carpo-metacarpal or the carpo-metacarpal pollicis joint, that it has a specific articular facet like a saddle, which is called saddle joint. Then here are the joints between the base of the metacarpal bones, is called intermetacarpal joints. And then following with the joints between the metacarpal bone and the proximal phalanx here in this joint is called metacarpophalangeal joint. And then finally is between the proximal phalanx and middle phalanx, and between the middle phalanx and the distal phalanx. They are called interphalangeal joint that we have in forefinger, two interphalangeal joint, the proximal and the distal, because we have three phalanges. But at the thumb region or the first finger, we have only one interphalangeal joint, which is only one interphalangeal joint between the proximal and the distal. So because the middle phalanx here at the thumb is missing. Wrist joint or the radiocarpal joint is between the radius and the proximal row of the carpal bone, except the pisiform. The articular facet is the carpal articular facet of the radius. You can see it here. We mentioned it here in the bones section. And the articular facet at the proximal row of the carpal bone, that they are making approximately a ball shape, ellipsoid shape. That's why this joint, according to the shape of the articular facet, is the ellipsoid joint. Here you can see. And according to the simple or compound, of course, you can see that is between the more than two bone. So 1, 2, 3, 4. So is compound joint. And another reason is that, very important, pay attention, dear students, that ulna, this is the head of the ulna, ulna doesn't have any direct contact with the proximal row of the carpal bone, because here, very well seen here there is between the ulna and the proximal row of the carpal bone is an articular disc. This is a triangular shape articular disc which is separating the ulna from the proximal row of the carpal bone. So this is very important. The ligaments and the capsule, the articular capsule, it's somehow lax, so it's allowing some limited movement, and the capsule is stringing by some ligaments that for the firming of this joint. The ligaments here in the both sides, they are called collateral ligament. Not to be mistaken with the collateral ligament at the elbow joint. The name of the ligament is the carpal collateral ligament. So if it is in the lateral side, it's the lateral carpal collateral, or if it is medial, so it's the medial carpal collateral ligament. Or you can say the collateral ligament of the lateral and medial collateral ligament of the wrist joint. And in elbow joint, lateral and medial collateral ligament of the elbow joint. So here, if you add the terminology of the lateral or radial or medial or ulnar collateral carpal or carpal collateral ligament, so we automatically we are thinking that you are discussing about the wrist joint. Another ligaments that they are not seen well here, so they are the ligaments that they are connecting the the radius and ulna, the distal part, to the carpal bone. It means that we have the palmar radiocarpal ligament and palmar ulno-carpal ligament, and also we have the dorsal the radiocarpal ligament. So two collateral ligament and two radio and ulno-carpal ligament palmar, and one dorsal radiocarpal ligament. They are the ligaments that they are firming the wrist joint. The wrist joint, it has the function together with another joint between the proximal row and the distal row that I said it, that is the S-shape joint, and this is called mid-carpal joint, and together they have a specific movement like a marginal movement and another movement in one plan that I am going to discuss it at the end. The next ligament that is classified as a joints of the hand is the joint between each carpal bone or two carpal bone together. So it doesn't matter that if it is between, for example, scaphoid and lunate, so it's a scaphoid or lunate joint, and then they are firming this joint by the ligaments like a palmar and dorsal and interosseal, here very nice scene, interosseal ligament. Only exception is the joints of the pisiform bone. Here you can see this is the pisiform bone that I said it, that is palpable, and its joining to the triquetrum bone is a separate bone joint because it has its own capsule. The capsule is very firm and rigid. The joint is very rigid, so that's why the type of the joint is amphiarthrosis, and it doesn't have a specific movement or minimum movement. The important for this joint is to the pisiform bone, the tendon of one muscle is inserted, and this muscle is called flexor carpi ulnaris, that in the muscle section we will show you. The muscle, the tendon of the flexor carpi ulnaris is inserting to the pisiform bone, and from the pisiform bone it continue to the two way. One way it continue to the hook of the hamate or hamulus of the hamate as a pisohamate ligament, and another continuation of the tendon of the flexor carpi ulnaris after attaching or after inserting to the pisiform is called pisometacarpal ligament, that it's inserted to the base of the fourth and fifth metacarpal bone. So the importance of this region is once more the insertion of the flexor carpi ulnaris to the pisiform and continuation it as a pisohamate ligament and pisometacarpal ligament. Then the name of the ligament we said that is connecting the carpal bone together, it's the same name of the joint between each bone, and also is divided to the palmar, dorsal and interosseous ligament. There is one ligament that it has a specific name, and it's located approximately here at the region of the head of the capitate bone, the small head that it has, and it's going proximally radiating to the proximal row of the carpal bone, or the carpal bone that they are locating in the proximal bone. So that's why it has a specific name which is called radiate ligament, because it's radiating proximally to the proximal row. Here is very important also, as I mentioned it already in the bone session. We have two eminences. One is in the lateral side or radial side. The other is in the medial side or ulnar side. This is the lateral carpal eminence, and here is the medial carpal eminence. And between them it was a groove, the carpal groove here. Here is a part of the ligament that it's transversally is connecting these two eminences together, which is called flexorum, the retinaculum musculorum flexorum. This is the Latin name, retinaculum musculorum flexorum, or the English terminology is the transverse carpal ligament. Transverse carpal ligament here is cutted, so it's like a bridge like this, So it's closing the carpal groove, and in this case, under this bridge-shaped ligament, there is a tunnel, which is through this tunnel it passing the tendon of the flexors muscle and very important nerve that is called median nerve. And in some people, especially ladies or female, usually the lunate bone is subluxating toward the carpal tunnel and is pressing the median nerve that is passing through this tunnel, and that's why when you are moving the flexion extension, this is cause compression of this nerve, and it has a painful and it's causing the pain during this movement. So there is a syndrome of the carpal tunnel, and can be operated by the removing of this pressure against the median nerve. Another clinically about this region, there are usually the most common fracture at the carpal bone is happening at the scaphoid bone. We are continuing with the another joints, that there are the joints between the distal row of the carpal bone with the base of the metacarpal bones. This is called carpometacarpal joints. The carpometacarpal joints, they are the joints. Here again, maybe it's much more better seen. The carpometacarpal joints in this area, we already mentioned that which bone is articulated with which bone. The distal bone, the trapezoid bone, is articulating with the first. The trapezium articulate with the first. Trapezoid bone is articulated with the second. Capitate is articulated with the base of the third metacarpal, and the hamate is articulated with the base of the fourth and fifth metacarpal. For this forefinger, except the thumb, the type of the joint is simple and is amphiarthrosis, because we don't have some tough movement. So this is a rigid flat bone that it doesn't have a typical movement. But very important is the articulation between the trapezium, the first lateral bone, carpal bone at the distal row, that it had a saddle articular facet with the base of the first metacarpal bone, that also it has a saddle articular facet. So this joint is called first carpometacarpal joint or carpometacarpal pollicis joint. And this is the simple joint because it's between two bones, and because of the shape of the articular facet, it's called saddle joint. And it has a specific movement that in a while I'm going to tell you. So dear student, the movement of the joints of the hand that till now we discussed. The wrist joint or radiocarpal joint that I said, usually they are working together with the mid-carpal joint between proximal row and distal row. These joints together, they have some marginal movement. It means ulnar duction and radial duction, they call it. Ulnar duction toward the ulna and the radial duction toward the radius. And some movement in one plan, which is called flexion and extension, or sometimes they call it palmar flexion and dorsal flexion also. So usually the simple is flexion extension and ulnar duction and radial duction. A small circumduction movement also, it can happen in this joint. What is important or what is interesting is when I do some marginal movement like this or like this, you can see that marginal movement in the ulnar side is more than marginal movement in the lateral side. This is why, this is because that first of all, here at this level we have the articular disc between the ulnar and proximal row of the carpal bone. And another important is that the styloid process, if you remember, at ulna it was smaller, but the styloid process in the radius is bigger and is extended more distally, so it's stopping this marginal movement. Another important joint that I already mentioned, it was the saddle joint at the first carpometacarpal between the trapezium and the first metacarpal bone or metacarpus pollicis. And this saddle shape is like a person that is sitting on the horse, in the saddle of the horse, and is moving. And this is very, very important joint, this saddle joint at this place, that is allowing you to do 30 till 40% of the work that you are doing with your hand. You can do it. So if there is a disorder of this joint, so you are losing control of some movement of your hand, about 30 till 40%. So the movement at the saddle joint at the carpometacarpal pollicis are the abduction, adduction. Then we have the flexion, extension. Then we have the internal rotation and external rotation. And then we have a specific movement only in this joint, which is like counting your finger, is called opposition, and vice versa is reposition. So it means if I ask you what is opposition movement in this joint, opposition is combination of adduction, internal rotation, and flexion. Adduction, internal rotation, and flexion. And opposition is combination of extension, external rotation, and abduction. So this is very important. Continuing the joints of the hand, the other joint that we have it is the joints between the base of the metacarpal bones. It's called intermetacarpal joints. They don't have a specific movement or it has very, very minimum movement in this region. So it's more or less is amphiarthrosis. Just there is one ligament in the palmar side that is connecting the head of the metacarpal bone. They are called deep transverse metacarpal ligament that is connecting the head of the metacarpal bone. Another joint that I already mentioned is the joint between the head of the metacarpal bone with the base of the proximal phalanx. As I already mentioned, the head of the metacarpal bone is a ball shape, and the base of the metacarpal, the proximal phalanx, it has one fossa. So the type of the bone is the joint is simple, and the ball and socket, and it has or is allowing the movement of the flexion, extension, rotation, the freedom in three direction. It can happening in this joint, and also the ligaments that they are controlling the movement, specifically the flexion and extension, they are called collateral ligament. As you see, is a simple and ball and socket joint. The capsule, it's allowing some movement in some more direction, but not that much. So abduction, adduction, flexion, extension, rotation, it can happening in this joint. Very interesting. You have some experience that if you have your finger, your palm open, so you can do this abduction and adduction your finger. But if you close your fist, so then if you try to open your finger, the space between your finger is not possible. This is because that the collateral ligament, they are tight and they are tough. In palmar position you can do it, but if you fasten your fist, it is not possible to open your finger from each other, or you do the abduction. Next joint is the joint between the proximal phalanx with the middle phalanx and middle phalanx with the distal phalanx. It's called interphalangeal joint. We said that we have, for these 4 fingers, we have the proximal interphalangeal joint and the distal interphalangeal joint. Since the head of the proximal phalanx and the head of the middle phalanx is a trochlear shape, and here we have always 2 fossa with the ridge between them, so the type of the joint is hinge joint, and in this case the basic movement in this joint is flexion and extension. So you can see the hinge, flexion, extension. In the proximal part or proximal interphalangeal joint, usually the range of the flexion is 110, but the distal interphalangeal joint, the range of the movement is approximately 90 degree deflection. And this movement, flexion, extension also is controlled by the collateral ligament in both sides of the joints. As I mentioned it before, so the thumb or the first finger, it doesn't have middle phalanx, so in this case we have only one interphalangeal joint. And at the end, just to again repeat that in this area, it means that the metacarpophalangeal joint in this area between the tendon of the muscle, it's existing to a small bone which is called sesamoid bone, and the typical position is in this area. Sometimes also the pisiform bone also is called as a sesamoid bone because it's located at the tendon of the flexor carpi ulnaris. Dear student, that's all about the joints of the upper limb. I hope you will like it. Again, I would like to thank my colleague Dr. Petrashek, and stay safe and study hard. Thank you for your attention.